I invite all our panelists to come on to their videos, as well as our speakers and presenters. So please do come on as well. And I'll pass over to John to introduce our new faces for the panelists. Thank you so much.
Okay, great. Thanks again to all the presenters. That was an incredible amount of information. Really was really rich and a lot to take in and to sort of digest intellectually and bring it together. So I think I really will start there with our panelists. I'd like to start with Nahida, Dr. Nahida Chakatura and Dr. Monica Longo, because I noticed that NIH was a funder of the study from Dr. Eke at Hopkins. So I was interested just to your thoughts about the range of studies presented, any comments you had about those, and how it was relating to the studies that you had funded in the past or were currently are planning to fund in the future. So if you could comment on that, I appreciate it. Thank you.
So, thank you very much. And I want to say thank you for including us in this panel. And it's great to hear all the presentations. I do have to say that we also support Catherine, so that so not just in the future. And so NICHD overall, including multiple branches within NICHD, including the obstetrical pharmacology branch, the maternal pediatric infectious disease branch, and the pregnancy and perinatology branch that Monica and I are in, have supported research related to hepatitis C in the past and ongoing. So we also have led the PregLac activities to help support and increase research in pregnancy and lactating individuals. And we continue to do that through multiple activities within NICHD and NIH with our FDA and CDC partners. So that's where we are. And I'm going to turn to Monica a bit to talk about some of the work that was recently done through the maternal fetal medicine unit. Just briefly to mention the last presentation that was done at the Society for Maternal Fetal Medicine. So I'll turn it to Monica for a minute.
Yeah, so I just want to congratulate all of you for the wonderful presentation you're doing. And I think the study that Dr. Chaknula Naida alluded is what has started. And I think you guys have taken from there to bring it more and understanding the pharmacodynamic and pharmaco that is working on about the treatment in pregnancy of hepatitis C. So what they did was a multi, as you know, is a multi-center study. These are 14 center, 26 hospital. And one of the interesting things I think that was just presented, which is not the main primary outcome, which you're probably already aware, is a secondary, was based on maternal transmission, vertical transmission, using those evaluating the viral and the mode of delivery and other characteristics, and to see if there was a possibility of coming up with an algorithm which could allow the physician, now then we might have a universal screening to see women that could be more beneficial, which you could consider now could be your target for the treatment and might make it easier. And actually they found then bleeding and antepartum bleeding, and of course maternal viral HCV titer are the most correlated with the vertical transmission, which is probably known, but at least now we have the data and actually not the mode of delivery. And that older than the viral load might not be that high, and we don't get a lot of preterm delivery, even when the viral load is not that high, that still we have a double of baby that are going to be in the neonatal intensive care unit, as well double of these baby that are going to be small for gestational age, less than the 5th percentile. So we're hoping with all of you to utilize this data to come up with an algorithm that will allow us for now then for the screening and the treatment, and might be allowed to understand, working with the FDA, where that population can be, if it can be more targeted at this point, knowing that there is significant consequence in that specific target. But this is my, and I would like to thank you for being, thank you for your wonderful presentation.
Thank you. That raises some other areas to explore, but I think to get everybody involved in the conversation, I'll turn it over to my colleagues at the FDA, Dr. Tamara Johnson, Dr. Yodit Ballou. Thank you for joining us today. And again, I would love for you to comment on this data. And I think for many on the webinar today, they may not know all of FDA's role in assessing safety and effectiveness of drugs after their license. So, if you would like to sort of let people briefly know how FDA does that and how these studies and perhaps our registry, helps with that FDA role of monitoring safety post-licensure. Thank you.
Hello, good afternoon. And thank you for the opportunity to participate in this webinar. Indeed, I'm sitting within the Center for Drug Evaluation and Research, the Division of Pediatrics and Maternal Health. And my group usually gets involved in consideration of safety with safe use of drugs in pregnancy post-approval. As you understand, when drugs come forward to the FDA, they have information from animal reproductive toxicity studies, which are helpful in understanding, but the animal experience doesn't always translate or predict the human experience, but it gives us a good indicator. We often have a very small number of human pregnancy cases, if we have any at all, from the clinical trial data. So where we find ourselves is trying to get more information for pregnancy, and it does result in looking at post-approval safety studies. The FDA may require these studies, and they would be observational studies such as pregnancy exposure registries that focus on the maternal infant outcomes. You can look at retrospective cohort studies, looking at claims database or case control studies, and then there are also surveillance methods. In consideration of where there are opportunistic studies in pregnant patients, one, consider exploring the collection of PK data. I can see from the studies presented here today in this webinar that there's a lot of work ongoing in looking into the safety in pregnant women, and a really good start with looking at the exposure of the drugs during pregnancy and collecting PK data. And that PK data is helpful because at approval, we have information regarding the adult population. The drug is approved for the entire adult population, and only if there is a contraindication for use during pregnancy or lactation, it would preclude use there. But what we are missing are the safety data, and then the more specific data about drug exposure levels during pregnancy. As already described, pregnancy physiology changes how drugs are absorbed, distributed, metabolized, excreted, and we need to understand that better.
Thank you. Dr. Ballou, any comments?
Good afternoon, everybody. And again, thank you for extending the invitation to the FDA. So I work closely with Tamara, and who sits in the Division of Pediatrics and Maternal Health. My role is I'm in the Division of Antivirals. So my division does the review process for drug approval, which of course is inclusive of a lot of the DAAs that we're talking about today. With respect to adding to what Tamara has said, I don't think I have anything additional to say, but I've also worked closely with Nahida in the past related to antiretrovirals in the HIV, treatment of HIV setting. So I think there's a lot to learn from our experience in how we've come such a long way with antiretrovirals, getting both PK and post-marketing safety information included after approval in a lot of the antiretroviral labeling. So what I would generally say that is, I think you all are doing a great work with respect to getting both PK and safety information, and any collaboration you can have with the manufacturers of those particular products, that would be the way to get the information generated to potentially be included in drug labeling. So we are always available to work with the sponsors of the manufacturing, or in this case, the DAA. So any collaboration you have, then we can work with the sponsors to get that information included for regulatory purposes.
Thank you so much. That really was that was my next question. So thank you for letting us know that this is the type of data that could lead to that kind of relabeling, by industry. And it's great that that your office is available to help along in that process. So thank you very much for that. Let me turn it over to Devika Bhattacharya, who is a researcher in her own right. So Devika, you may have comments on the research, but you're also here representing AASLD and IDSA, and I thought it'd be a great opportunity to briefly mention what guidance are coming from both of those professional organizations as it relates to pregnant women and infants exposed to hepatitis C virus. And given what you've heard today or some other recent data, are there any considerations that need to be put on the table as those guidance documents are updated?
Thanks so much, John. And so first, also want to really congratulate all the speakers, outstanding presentations. And there's a lot of very interesting data that we on the guidance panel are going to be looking forward to. And also thank you to the organizers for having me. My role in the guidance panel, I'm one of 4 co-chairs of the AASLD, IDSA, HCV treatment guidance panel. And the way the panel works is, there are a group of about 30 plus physicians who are involved in the panel, and we have routinely scheduled meetings where we discuss updates in the data, and also obviously that extends to hepatitis C and pregnancy. And then we make updates at this point twice a year, both on a web-based platform, and then every 2 to 3 years we produce a manuscript that reflects key issues or updates. And so the current guidance for hepatitis C treatment in pregnancy is that it can be considered on a case-by-case basis, but we just do not, as individuals here have so eloquently pointed out, we just do not have the robust data yet to put it in our very familiar green box, where we make those recommendations. And I think, moving forward, the types of data that we, as a guidelines panel, and I have to be very careful because, we can, I want to make sure that I'm saying that the things that I'm discussing here are kind of publicly known and are, and what is presented is going to be presented kind of externally in the guidance. But in general, obviously randomized controlled data are preferred, but we acknowledge that this is one area, particularly in hepatitis C in general, where single arm studies are likely going to be acceptable. And of course, we would like to see large scale studies evaluating both the safety and the efficacy, particularly SVR12 rates in pregnant women, and then also post-treatment outcomes and postpartum outcomes. I think the other thing I would like to put a pitch in for is for the inclusion of women living with HIV, and also the inclusion, although we are kind of a US and North American based guidance panel, we have page views from all over the world, including high page views from both India and Pakistan, and really want to emphasize and really credit researchers in the UK that are planning these studies in international settings, because we really need to understand, kind of what's happening in diverse populations, and those would be welcome. Also really excited to hear about the impact collaboration, and really hope that will be one that will also be conducted ex-US. So I think I'll stop there. And then I have a question for Dr. Woodworth whenever it's time, but thank you.
Okay, thank you very much. Well, let me welcome Dr. Jody Dion from my medical school alma mater, UAB in Birmingham. It's great to have you on, Jody. Just please tell us how what we've presented today relates to your work at UAB, and what you see going forward as important items to consider to better know the safety of these medications for these populations.
Yeah, thanks, John. Thanks, Neil. I want to echo the great presentations, really terrific so far. To me, what I think, we are at this really opportune time, and all the work that you're doing, this coalition to work for global elimination, is coming together nicely. I think that we have learned a lot from the HIV epidemic over decades about how to do good PMTCT trials, how to start them early and not late, because it takes decades to get data approved and all the data that we want. And we've just lived through a pandemic where we see that not including young women of reproductive age and pregnant women and breastfeeding women puts us behind for a long time. And that vacuum is filled with misinformation and disinformation for these diseases that we know pregnant women are particularly vulnerable to. So I think the world is getting it. I think that Preglac, mentioned by Nahida, has done an incredible job of saying these are the barriers, that we all have something to do, whether you're FDA or an investigator, whether you're regulatory, we all have to recognize the protection through research, not from research, for women who are pregnant who want to enroll. Dr. Chappell, I have to tell you, your work has been cited, your study, at least 8 times in the past 4 months at talks that I've gone to and given myself. The trials that are coming out are there's so much salivation for them. At the SMFM conference a few weeks ago, the room was full of MFM. They all wanted to know how to treat and when and with what and when to start. All of these require clinical trials. When I was on the SFMFM hepatitis B treatment guidelines, you can't recommend a treatment if there's no data behind it, even if we think the preliminary data look good, even if we think it's very promising. You just can't put a good recommendation, like Devika was saying, on it without the data. So I think let's use this momentum. Let's use the power that we have wherever we fit on the spokes of this wheel to move this forward. And I just applaud everybody for what you're doing. We're getting there, but it's going to take a lot more work.
Well, thank you, Jody. You were the perfect closing panelist. Thank you very much for that. I think we only have 2 minutes left. I think I want to thank everybody for coming. If you have a very short question, Devika, I'll let you wedge one in here for Kate.
Oh, thanks so much. Just a query as to whether or not cholestasis is going to be captured, since that's been associated in pregnancy and HCV. Thanks.
Yes, we do have a variable to capture that cholestasis during pregnancy. But good to know that's of interest.
Can I ask one quick question, please?
Yes.
Hi, Dr. Chappell. Thanks a lot for, and I echo Dr. Diane's words at SMFM. Quick question. So based on your PK data you showed that there was an increased exposure despite normal time to maximum plasma concentration. Do you, in this tox study, are you guys using the same dose, or do you think that the dose should be reduced based on that PK data?
No, we didn't have any any idea that we would see that. So we use the typical old Epclusa dose, and that's what we saw. But again, there's no evidence that there's any toxicity. But also we're still doing a lot of PK work, PK modeling in pregnancy, as well as looking at the intracellular for sibosavir. So so more to come to really kind of figure out what is going on. But again, there's no evidence that there's any toxicity.
Sounds
Thank you.
good. Thank you.
Thank you so much. I think we're right on 1:30 Eastern time. Neil, do you want to make some closing remarks?
No, just to thank everyone, speakers and panelists for their participation today. Obviously, a lot of moving pieces here. The coalition, our objective is to really bring everyone to the table, and we're at the table. So this had been a very valuable experience. This is the closure of our first phase of the community of practice. We'd love to see it continue. Please do reach out, let us know what your experience has been through the community of practice. Lindsay is posting a poll here just for a few parting questions for you. But with that, and as soon as you finish with the question within the poll, we'll say thank you very much, and looking forward to working with you all as we push this agenda forward and really make sure that the inclusion of pregnant persons within hepatitis C elimination is a reality in the years to come. So thank you all again, and we look forward to continuing collaboration with you all. Thanks so much.